So glaucoma drainage devices. So many people don't know glaucoma drainage devices actually appeared on scene around the same time as trabeculectomy did. They also have a very interesting history, and I enjoy the kind of interesting stories of history, which is funny because when I was a student, I hated history. It was dry and dusty, and probably because that's the way it was taught. But now we've discovered, through the wonderful PBS documentaries that, well, history can be pretty interesting, and it is, and it's true in our own fields, right? Glaucoma drainage devices also have an interesting history. The first drainage devices out there were called cetons. Cetons are basically just a filament, something that you put in a position to keep a hole open. So they're not tubes, they don't have any lumen inside them, they're just something, it's a placeholder. And some of the earliest cetons that were described in the literature include horsehair, glass, and then every precious metal you can think of. But none of them really worked so well. So they all basically scarred down or became infected, or the cetons basically were extruded. So glaucoma drainage devices were the next step. And what really made glaucoma drainage devices work is that instead of just putting a kind of tube in the eye and letting fluid flow from the anterior chamber underneath the subconjunctiva, the key is that there's a plate. So essentially a reservoir forms. Right? So the fluid moves through the tube onto the plate and then out, usually through subconjunctival space into the drainage vessels. Now, the problem with glaucoma drainage devices is that it can be difficult, just as with trabeculectomy, to achieve that right balance. Because the tubes that we currently use with glaucoma drainage devices are all the lumens are so large that there's really no significant restriction to flow. If you just put them in and let the fluid go, everyone's going to be hypotenuse. And indeed, that's one of the issues with glaucoma drainage devices, which is why with Barvelts, we have to tie it off for a period of time and basically sit there and wait while it opens up, which means, of course, that the pressure's too high during that time. Or with the Ahmed, there's actually a valve which does restrict the flow a bit. And in the lab, it works beautifully in terms of flow restriction. But in humans, for some reason, you can still get hypotony. So early on after surgery, you can still get too much flow, even though there's a valve or a flow restrictor that should, in theory, keep it from going too low. And then, of course, there's the issue that a month or so out, most patients who have glaucoma drainage devices end up with what we call a hypertensive phase. Well, the body is going to heal around this. And as it does so, you end up with more restriction to the outflow, and you can actually end up with a hypertensive phase before the healing process is completed. And then, of course, it depends on how the body heals long term. If somebody develops a very thick wall of fibrous tissue around these devices, you're not going to end up with a good long-term result. And then there's all the issues of just an implant. And this is true of any implant you put in the eye or anywhere else in the body. The implants can move, right? Implants can get infected. And then an implant that gets infected has to be removed, right? Scarring can result in things like restriction of the tissue around these implants, and at least in the case of the Barvelt, which sits underneath the extraocular muscles, you can end up with double vision. Okay. So these are the basic glaucoma treatments that we've had available for decades. And for those who have severe glaucoma and there's nothing else that we can really offer and we're facing loss of vision, it's been a trade-off we've been willing to accept. We've been willing to accept it. I'm not so sure that our patients have been so willing. But in the past, patients were also much more likely to just do what their doctors told them. That's no longer the case. And I personally am getting more and more patients, when told that they need trabeculectomy or glaucoma drainage device, just say, no, I won't have it. And I'd rather go blind. And I just had somebody in my office the other day. It was a little stressful for me because she was adamant she didn't want trabeculectomy, and her son were arguing in front of me. He was telling her she was going to go blind, and I was agreeing she would if she didn't have her pressure lowered. Fortunately, she did have other options, but I mean, prior to coming and seeing me, the only option she had been given was trabeculectomy. And her surgeon was not willing to even consider any other options. So, we have to be willing now to accept that we need to work with our patients, and they do have the right to determine what happens to their eye, just like they have that right to determine what happens to any other part of their body. And we may not agree with their decision. So it's good now that we have a number of these newer technologies and procedures that we're going to be talking about. So this is just the a couple of the risks of glaucoma drainage device. Here's a tube that's eroding through the cornea. This here is a suprachoroidal hemorrhage. This can happen after any glaucoma surgery, but it's more likely after trabeculectomy or glaucoma drainage devices because there's the potential that your pressure could end up too low. If your pressure is too low, you can actually end up with the choroidal vessels leaking or bursting. And this is a blinding condition, the suprachoroidal hemorrhage. So let's move on to some of the newer technologies.